Anna, hi.
Okay, what?
Well, hello everyone. Welcome to this jointly hosted ICN and JSNO, our joint Swedish nursing organisation hosted webinar on the State of the World's Nursing Report, just recently launched on the 7th of April. Some of you I know may have just got out of your beds. Perhaps you might even still be in bed. It's early in the morning. Some of you, like me, may have sandwiches with you at lunchtime. Others of you may well be towards the end of your working days, perhaps have something a little bit stronger. But you are all very warmly welcome to this webinar. It is jointly hosted between ICN and JSNO because some of you will be aware that a number of us should have been in Stockholm today and for the next couple of days for one of the regular ICN workforce forums, which the JSNO had very kindly offered to host for reasons that we're all aware of. Obviously, that was not possible. And I know a number of colleagues were disappointed at that because part of the venue, as I understood it, was going to be attached to the ABBA Museum in Stockholm. So yes, we were disappointed, but I guess that's the name of the game given COVID. But we thought, knowing me, knowing you, that instead we'd gimme a webinar instead. I will stop there and say no more. We are very pleased today to have Carrie McCarthy and Matthew Bonnell from WHO. If you didn't know them before, I'm sure that you're very familiar with their names, having looked at the State of the World's Nursing report. Carrie was a lead author and Matthew was leading on data collection and the data analysis. We're very grateful to the both of you for joining us. We're delighted, as I said, to be able to jointly host this with JSNO, and Sinead Ribeiro, the JSNO president, and Amy Hamel, the vice president, are also with us and will be speaking later today. And we are also very fortunate to have somebody who's very well known to us at ICN, Professor James Buchan, recognised global nursing and health workforce HRH expert. Jim's been working more closely with us over the last couple of years, and some of you will have met Jim when he's attended workforce forums over the last couple of years. So we will be hearing from all of our panelists, but having the time for questions and answers as well. If I could ask you, please, if you have questions, please use the question and answer tab. We'll be monitoring that during the course of the webinar. But if you just have observations and want to chat, then please use the chat tab. This webinar will be recorded. We will do a report afterwards, as well as addressing questions and answers. If there are interesting common themes and observations that merge through the chat, we will capture those as well. And we have 90 minutes today. So without further ado, and for somebody who needs no introduction to you, on whom the sun always shines, and I believe the sun is shining on her right now, our ICN President, Annette Kennedy. Annette, over to you.
Thank you, Howard. Good morning, good afternoon, good evening, everyone. From a sunny Ireland, unusual as such. I thought we would be in Sweden, and I thought I would be in the ABBA Museum. But I'm sure Sneeva and Amy will get me another invite someday soon because I'm a fan of ABBA. Anyway, we're in Ireland, we're virtually in Sweden, and we're virtually in Geneva and wherever else you may be. I just want to say thank you to WHO, to Nursing Now, and to Howard for the very valuable report that we have now in our hands. Today's webinar is about you finding as much information as you possibly can, that you discuss and you provide questions and you make observations, and it's your time to tell us more about what you think about the report. I would like, first of all, to thank all of the nurses and the nursing associations for your great leadership, for the support and the protection that you've given to your nurses over this very unfortunate time period in our lives with COVID-19. It's true to say that give nurses a challenge and you will see the true leadership of our profession. ICN has been trying to support you in any way we can by providing information, by lobbying at the very top levels with the governments, with WHO, with G20, and working with our other professional colleagues to support you in every way that we can, looking for protective equipment, looking for support, knowing how much you are going through and how much the nurses are going through physically and psychologically. And we have been doing that since very early January. And we're very grateful for all the information that you have given us, because that has been so valuable in disseminating that across the world to our other colleagues, because we are a family and we share all of that. So we have an area on our website, COVID-19, it's a dedicated site to COVID-19 with all the information we can possibly get from all the agencies and from you. We launched our ANP guidelines, which has gone down very well. But I'd just like to say a few words about the state of the world's nursing, some things that came to me as being very valuable. As you know, it's the first report on the state of the world's nursing that we have ever had. We've known a lot of the issues that have been there. We've known through our associations, through our countries, but we haven't had an independent review. We haven't had that independent evidence that we now have. A lot of what's in it is very valuable for us going forward. And when the report was being launched, we thought the timing wasn't great. We thought, first of all, right in the middle of COVID-19, launching it on World Health Day was not a great idea. But I personally believe it's the best time we could have, because we have seen the value of nurses. We have seen their contribution during this pandemic. We have seen that we cannot do without nurses to actually curb this pandemic. We have seen that we have been looking for our retired nurses to come back into the workforce and for our students to help in the workforce. There's no better time for this report to be launched, to my mind. The report, of course, is 58% up on last year in the number of countries that have reported. 191 countries have reported, 6 million short. And that's very important that we know that right around the world, and that we know that 80% of the nurses work in 50% of the countries, and 1 in 8 of our nurses work in a country other than their own. That is very important to know, because we have had various comments and various illusions about the nurses. In some countries, there is an oversupply. That's an illusion and that's a myth, because there is no country in the world that has an oversupply. What we have is health systems that are weak, that are not investing in the health workforce or in the health systems. And so consequently, we may have nurses that are not employed. But that's very different to saying that we have a surplus. So we have to get rid of that myth once and for all. We have an older age population, mainly in the West and mainly in North Africa. And that's important for us to know that. It does say, which we have known, but it hasn't been very clear to everybody else, that we don't have a workforce that's commensurate with universal healthcare, with the implementation of the Sustainable Development Goals, with the curbing of NCDs, or with the curbing that we see now with our pandemics. And that has been coming down the tracks for such a long time. But we see now the value of actually investing in a workforce, and that has a nursing workforce that's equal to all of these global issues. The recommendations are clear: investment in education, building capacity in our workforce, recruitment, retention, decent work practice and incentives. I know that you've all been calling for a lot of this, but this now is at a global level by an independent organization. Nurse-led services, we've been calling for that. That's very clear in the document. Improving our numbers of advanced practitioners and the work that they can do. Nurse leaderships in all areas in policy and strategy. And of course, we need to monitor the ongoing investment in the nursing workforce. Particularly, we need to look at attrition, retention, migration, and retirement. So I know that Carrie and everybody else, and Matthew and Jim, will have a lot more issues to say about the report, as will Suneva and Amy. But those things are issues that we have been talking about, but it's very clear. We couldn't get a better document to portray the issues around nursing, and we couldn't, to my mind, get it at a better time. So I will leave it over to you because it's your time. Thank you, Howard.
Thank you very much, Annette. And as you said, ICN, along with our friends and partners from Nursing Now, were delighted to be able to co-chair the production of the report with WHO. And colleagues who attend the workforce forums will know that we always produce a communique at the end of each of the workforce forums that we hold around the world. And those communiques from the workforce forums that have been held in the last 2 years were very important, very influential. We as ICN use them in the discussions that we had with other colleagues in WHO to inform both the report and the recommendations and directions from the report as well. So colleagues who participated in workforce forums and who were on this webinar, to recognise that you have made an important contribution to the production of the report. But now over to Carrie and Matthew. Please do take us through in more detail the first ever State of the World's Nursing report. Carrie, to you.
Thank you, Howard. Thank you, Annette, for that great introduction. I want to say thank you again to ICN for the leadership on the steering committee with Nursing Now, which was really pivotal for the development and refinement of this report, and to our steering committee overall, which was made up of a mix of a lot of nursing and innovation and education leaders that really helped guide this as well. And thank you to the Swedish Nurses Association. I was so looking forward to coming to Stockholm. So it's good to be with you virtually. And I hope that, like Annette said, there's other opportunities in the future. I'm going to share my screen and do just an overview that we are asked to do to give you some of the main findings of the report. Okay, Howard, let me know if this isn't coming through clearly.
Yes.
It's looking good, Carrie.
Okay, thanks. Matthew and I are going to go over this outline, the background methods, the main findings of the report, and the policy options that we're putting forward to member states and other key stakeholders. The link to the report, as well as the country profiles for all of the countries who provided data, which Annette said is over 190 countries, are also online through that link. Just by way of a quick background, the global strategy for human resources for health is our overarching policy framework for strengthening the health workforce to achieve the SDGs and achieve universal health coverage, and focusing also on how to fill that shortfall of 18 million health workers that we estimated to reach the health-related SDGs by 2030. The second document is a UN high-level commission on health, employment, economic growth that showed really clearly that investment in health and the health workforce is an effective way to make gains, not just in health, but also in other areas of SDGs like education, gender equity, decent work, and inclusive growth. And lastly, there was a recent report that was sort of our pulse taking on how we are on the road to universal health coverage using primary health care as a main approach. And it showed we still have a ways to go. There have been gains, but there have been ways to go. And we know that investment is crucial, and we won't reach universal health coverage without a substantial investment in the health workforce. So that really sets up the State of the World's Nursing Report. If we can have strong, robust country validated data on the nursing workforce, which is a little over half of the health workforce overall, that's a fantastic start and a fantastic basis on which to make evidence-based decisions on where and how to direct that investment so that the impacts on primary health care and universal health coverage and the other SDGs are maximized. So that was the rationale behind doing the State of the World's Nursing Report. I'll just mention, so our big picture theory of change is believing that if we have broad engagement of all the critical stakeholders to nursing and the health workforce, and we can have them report and share their country data on these key areas of the nursing workforce, that is the basis for intersectoral broad policy dialogue at a number of levels, national level, but as well as decisions that can be made at the regional and global level, that fosters then the decision making and these key areas around education, practice, regulation, migration, everything Annette mentioned that are key to our SDGs, and that can lead to investment. And we want sustainable investment at a domestic level, regional, international, in these key areas of education, jobs, and leadership. And we have good reason to believe that if we have that investment based on these steps, that we can achieve not just impacts in health, but also those other SDGs that you see. Now, in terms of the global strategy for human resources for health strengthening, as well as the State of the World's Nursing Report, I just want to mention that we use what we consider a health labor market framework, basically starting at the right-hand side. If we're achieving universal health coverage and these other goals, we want to make sure we have an accessible, adequate number of health workers. We want to make sure that in the health sector that there's adequate health service delivery models that are appropriate. And if we move left, we know that the pool of health labor market, the pool of nursing workforce is based on those that are educated, which is that education sector to the left, those that are produced domestically within a country, as well as those that come in through migration. So we use this to kind of assess where are the levers for policy development or reform that are going to help address the failures in the health labor market. And so when we go over the policy options that we're putting forward based on the data and the evidence synthesis that we did, we're going to be looking at those areas of education on the left, of those in and out flows with migration and graduates, bringing nurses back into the labor pool, how to retain them in the labor pool, and then in the practice setting, what are the key areas for retention, for productivity, performance, for advanced practice of nursing, and also the regulations, private sector and others. So we'll come back to these in the policy areas. Right now I'm going to turn it over to my colleague Mathieu, who's going to go through the methods and the findings of the report, and then I'll come back in to highlight some of the key policy areas that we hope will be the focus of those policy dialogues that are going to hopefully catalyze the decision making and the investments in the nursing room. Over to you, Mathieu, and I will advance your slides for you.
Thank you very much, Carrie, and thanks ICN for organizing this webinar. I will go through a series of slides to explain how the State of the World Nursing Report was elaborated about the data and presenting a few key results. Of course, with the limited time, I can only present some highlights. On the way the data were collected, we used what we call the National Health Workforce Account approach. which you might have heard of, which is a system for strengthening the human resource for health information system to improve the availability, the quality of data, and also the use of data. And why we use this NHWA, National Workforce Account, is also to ensure that the data will be sustainable, that this is not a usual survey where we collect the data once and these data are static. The data will be continually collected on health workers and in particular on nursing. The data collected are also standardized. This means that the National Workforce Account defines a series of definitions on key indicators, and for the report we used 30 NHWA indicators, as well as some additional specific indicator for the zone. The data was gathered at the country level. It's a country-led activity with the Ministry of Health and GCNMOs involved in this data gathering, and also with some engagement with different stakeholders, because that's also the role of the National Workforce Account, is to improve the reporting by engaging with the different stakeholders that include national nursing stakeholders, other ministries, HRH observatories, and others. And we also conducted a series of workshops in all 6 WHO regions. Next slide, please. So the first thing that you can want to know is how successful we were when we collected the data. And this is just to show you that we improved a lot the quality and the quantity of data. In particular, on nursing workforce, the graph you see here is the number of countries reporting every year on their workforce. And you see on the right-hand side that a lot of countries reporting on their nursing stock, which was not the case in the past. And we have more than 190 countries who reported data. 83% reported stock data for the years 2017-2018. So it's a huge increase in the availability of data. And it goes beyond the stock because, as Carrie mentioned, we want to know things along the health labor market framework. And 80% of countries provided at least 15 indicators. There are gaps, of course. There are some difficulties. For example, gathering information on education capacity, finance is difficult, but it's really an historical high in the data reported at the global level. Next slide, please. On the stock, how many nurses do we have worldwide? From the data we had reported by 191 countries, for the year 2018, we reported 28 million nurses worldwide. You can see that they are not distributed evenly, and it shows that there are some great inequities in the distribution of the workforce. And you can see that on the map on the right-hand side, the density of nursing personnel per 10,000 population, and you see places where you have much less workers. 80% of the nurses are in countries that represent 50% of the population. And there are huge gaps, in particular in the African, Southeast Asia, and Eastern Mediterranean region. And we estimated the shortage of nurses globally, which was estimated to be around 6 million nurses. And that's a shortage comparing the density to benchmark statistics. It doesn't mean that in some places that there is no shortage. It just means that it's at least 6 million nurses shortage. Next slide. Now, to describe a little bit more the nursing workforce, and here on the left side you see the type of nurses that we include in the report. For the defining who is a nurse, we use the International Standard Classification of Occupation from the ILO, because we needed to use a definition of who do we consider a nurse, and we use this occupational grouping. And you see that 69% of the nurses are professional nurses. We also included statistics on associate professional nurses. And for a few countries, some nurses it was not possible to classify them either as professional nurse or associate nurse, because sometimes there are some difficult cases for classifying nurses. Nurses are mainly women. 9 out of 10 nurses are female. And there are some important variation. You can see that on the table on the right, with the African region, where the female to male ratio is 3:1. And in some countries, we observed more male nurses than female. It was only in 13 countries, but this occurred. Next slide, please. Now on the age. We got data from 106 countries who provided data on the age of their nursing workforce. Globally, we saw that 38% of nurses are aged under 35, compared to 17% age 55 plus. So it means that we have more younger nurses than older nurses at the global level, but it's not the same everywhere. In particular, in America, Europe, and Africa, where we have more older nurses than younger nurses. And you see on this graph, we plotted the percentage of nurses age 55 plus on the y-axis and percentage of nurses less than 35 years on the x-axis. And what you can see is that the dots in red are countries where we have more nurses age 55 plus than nurses age less than 35. What does it mean? These nurses age 55 plus are nurses who will be certainly retiring in the coming 10 years, while the nurses less than 35 are those who entered recently in the market within less than 10 years. So that means that in this country, there will not be enough replacement capacity of nurses, and they have an important aging workforce. That means that their stock will very likely decrease in the coming years, which is a real issue. Next, please. Now that we've seen the stock and description on the nursing workforce, we also looked at some other factors like the mobility, which was mentioned by Annette. And we observed that from data from 86 countries that 1 nurse out of 8 was born or trained in a foreign country. This statistic gives us just a snapshot. It does not tell us about the flow on the annual flow on the migration on workforce, but it tells us the current situation on those who were foreign born or foreign trained. Unfortunately, we are not able to have some further detail and further breakdown because there are some reasons why some are foreign born, some foreign trained. Foreign trained could be the fact that there are some lack of capacity in training in the country and their reliance on training capacity in other countries. And you can see on these snapshots, on these statistics, that the share of foreign-born, foreign-trained is not the same by income group. And you see that the high-income group in particular have an important share of foreign-born or foreign-trained nurses. And this is an issue and will be tackled by the WHO Global Code of Practice on International Recruitment. Next, please. On the education part, we saw that the majority of countries have a 3 to 4 year program on nursing, which is a good thing. That shows that it's, and that's the case, it's a highly professional training. And we also gathered some statistics on the graduation of nurses for nearly 100 countries. And we saw that there was an average of 22.6 graduates nurses per 100,000 population. And these statistics will be used later when we'll be describing what is the future of the workforce. Next, please. We also got some data on the regulation, and overall, when we looked at the regulation on the education or the regulation on the working conditions, we saw that most countries have in place nursing education practice and regulation. And looking in particular on the advanced nursing role, we saw that 53% of countries reported having advanced nursing role. Keeping in mind that these statistics are self-evaluations by the countries. So they might respond that they have a regulation in place, but maybe these regulations are not enforced, that's something that we cannot know, but it gives an idea of where are the strengths, where are the weaknesses. So there are some good, a lot of regulation on working hours, social protection, but you can see that there are much less on the measures to prevent attack on health workers, which could be an issue with only 37% of countries with such regulation. Next, please. We also looked at the leadership and governance statistics by asking the question, do we have a chief nursing officer position? And do we have nursing leadership development program? And we saw that 71% of countries declared having a chief nursing officer position and 53% nursing leadership development program. The interesting feature that you will see in the report is that the fact of having a chief nursing officer position or having a nursing leadership development program, both were associated with improved regulations and significant improved regulations. So that means that these positions and this leadership had actual impact in the availability of regulation on the nursing workforce. Next. And from there, we also looked at what are the future about the nursing workforce and how the trend look like if we project the nursing stock to 2030. And to do that, I talked earlier about the age and I talked earlier about the graduates. We took the stock as of 2018 and we removed progressively those who will be retiring, and we took into account the graduation rate. So that gives an idea by 2030 of what will be the distribution of the nursing workforce in 2030. And unfortunately, you see that on the figure on the right-hand side on the map, the distribution of the nursing workforce projected in 2030 does not differ that much from the current situation in 2018. We projected that there will be an increase indeed from the 28 million in 2018, which will reach approximately 36 million in 2030. But the bad news is that the 70% of this increase will occur in the upper middle and high income countries. And the density in, for example, African region, which is one of the regions with the lowest density of the nursing, is projected to improve only very marginally. You see that in many countries, the projection shows that the density will be less than 20 nurses per 10,000 population. Next slide, please. For those who are interested, I invite you to go through the National Workforce Account online portal. I will give you a link in the chat in a minute to get access to country profile, because that's something that we developed to derive a series of key statistics from this data collection, where you will get stats on the stock, on some education statistics. You will see the trends like you see here in the middle of the graph with the projected workforce in terms of density and stock. You will see the share of the workforce, which as compared to other occupations like doctor, midwife, dentist, pharmacists. Some regulation statistics on the left-hand side to let you know what is the current situation in terms of the different regulation on education, working condition, practice, and some estimation of shortages for countries where we provided an estimation of shortages. That doesn't mean that there is no shortage in the other. That means that it was not estimated because the density was already high and it was not possible to use a benchmark. Over to you, Carrie.
Thank you, Mathieu. All right, so we're going to go through some of the policy recommendations in the report. There are approximately 20, so I'm not going to go through them in great detail, but just to give you a sense of what is being proposed, and hopefully these are things that resonate with you and that you can take forward in that policy dialogue process that we talked about. So as I mentioned, that health labor market framework in terms of understanding where are the most effective levers to address some of the failures in the health labor market. So one of those areas was production of nurse graduates. So there's a set around education capacity, financing and quality, those in and out flows that are related to migration, as well as other ways to enter or leave the health workforce. There's a productivity, performance, and management. So when you're in the health workforce setting, what are some of the key policy areas, as well as regulation of private sector and education and practice. So this one is mainly about grouping some of the education-focused policy options, and they focus around the quality and the types of nurses. So that might be something that a country wants to look at in terms of how many levels of nurses are, what are the entry requirements, what are the specializations, and how do those match with the health workforce, the health system, the health service model, and the population health needs. We think it's important to increase the demographic and geographical diversity of students and faculty, as well as to have an intersectoral engagement across a number of key stakeholders to advance these education areas. There's obviously needs to increase the number of graduates, so to increase the capacity of institutions to accept students, admit students. You need enough faculty, you need appropriate infrastructure, you need enough clinical placements to be able to educate those students, and using appropriate financing and levers and modalities to get to that goal. We also recommend a competency-based curricula and appropriate use of available technology. And there's more information, a lot more on all of these policy options within the report. In terms of the in and out flows, we're really talking about how to ethically and responsibly manage the migration and mobility, international mobility of nurses, and that relates to both domestic production and retention, as well as recruitment from certain countries. So as Mathieu mentioned, one of the big mechanisms to do this is the WHO Code of Practice, the international recruitment of health personnel, so advancing that among member states of WHO and key stakeholders. And also the National Health Workforce Accounts is a system through which countries report their workforce data, which does always reflect the foreign-born and foreign-trained workforce. We also look at how can regulation facilitate safe and managed migration. So there's a role there for seeing how to advance regulation frameworks and the communications between regulators in different jurisdictions. This also relates to the recruitment and retention and deployment of nurses, so how to have those policies in place that are equitable and transparent, and anticipating the retention challenges. We know in a lot of countries it has to do with the working conditions and the pay and the profile of nurses and the status of nurses, which has a lot of gender dimensions to it. So there's policy options around those in the report as well. The third area is really in the practice setting. So we're looking at practice of nurses, working conditions, and leadership that can really advance how services are delivered and their impact on patients and communities. One of our key policy options is about nurses working to the full extent of their education and practice. And that may be advanced practice roles where they are in country, or other nurse-led models of care, working to the full extent in areas that we know nurses are extremely effective in terms of primary care, NCD management, preventive services, all of those. So that's a clear policy option that we're hoping countries take up. There's also the decent work environment, enabling conditions for nurses, and those gender-sensitive policies. The social protections that are key, especially in areas that are fragile or conflict settings or other vulnerable settings. Other policies on violence and sexual harassment. As Mathieu mentioned, we saw some really important relationships between having a government chief nurse, that key leadership position, as well as leadership development opportunities. So we're saying as a policy development that there are government chief nurses, and they work as full partners with other healthcare leaders, and we advocating for that, develop those leadership development programs, and that the nursing perspective is integrated into the health policy development and health system decision-making levels. And then lastly, regulation of the private sector. So in ensuring engagement with the private sector so that we have, and regulators, accreditors, so that we have that no difference in quality between private and public sector education, practice settings, and that requires, that also helps in terms of the collaboration, the data reporting, all kinds of aspects. And I mentioned advancing regulation frameworks as well, balancing what's needed to be dynamic and flexible in this digital age with the right touch to ensure that public safety is still upheld. And also that might mean increasing the capacity of regulators and updating the regulatory systems and interoperable databases and other ways that the regulatory frameworks can be modernized, so to speak. So in conclusion, our real big top line messages is that we have to increase investment in the nursing workforce in these key areas of education, jobs, and leadership. As Annette mentioned, we have a shortage of almost 6 million nursing jobs, nurses, and those are primarily in these countries that can least afford it, that are already the furthest from achieving UHC and having strong primary healthcare systems. So that's where our focus needs to be. In the report, thanks to some of the analysis by Mathieu and colleagues, we can estimate that to have enough nurses by 2030, we would really need to increase production by about 8% a year in these countries, along with an increased ability to employ and retain those nurses. And looking at some costing scenarios, that could be about $10 per capita per year to 2030 in those countries. So that's something that we really need to facilitate and drive these investment messages. And in all countries, it's about building that nursing leadership that we know is effective and advancing those key agendas for practice, gender, education, and employment. And then adoption of these policy options. These won't go anywhere unless we have a mechanism. And as Annette mentioned, we have momentum right now with a focus on COVID and nurses and midwives' role in addressing and planning in response to COVID. So now is the time to highlight the nursing workforce, the gaps and the priorities and the policy options. So later, if we get a chance, we'll talk about some of the policy dialogues that we're hoping SON will catalyze and WHO's role in supporting countries to hold those. So I'll stop there. Thank you very much.
Harry, Matthew, thank you so much. It was to condense the 100-page report, which is packed with data and information into that presentation, was excellent. Colleagues, I think I also should share with you that I know that for our colleagues at WHO, getting this report out in April took huge effort on their part. Their holidays and Christmases were cut short as a result of this as well. So just for the record, it's a huge appreciation to the workforce team supported by the nursing colleagues at WHO for getting us to this point. I would just also something that Matthew said as well, but I know a number of you on this call will be familiar with looking at some of the data and will be alive to some of the caveats around the data. Matthew mentioned that some of the data is self-evaluation. We've got some binary responses. It's important to check how many countries responded to certain questions when you're looking at what the results are as well. Carrie and Matthew pulled out the issue around CNOs, which is really important. But though many of you will also know that at the beginning of the year, ICN did a report where we dug a little deeper on CNOs, and whilst the report has a top line figure of 70%, it's an example of where I'd urge you to also look at the additional report that ICN did, because when you dig a little deeper, then those roles may not have the full range of responsibilities, albeit the level within an organization that you would expect. So there are some caveats, but fabulous that we have for the first time. I can't believe it is the first time that there is such a report, but we do have it. We do have it now. So let me now go to Geneva, the president of the JSNO, for some reflections and reactions. Geneva, over to you.
Thank you, Howard, and thank you, Matthew and Carrie, for the report. I'm very happy of that. I'm very sorry that we couldn't be in Stockholm and that we couldn't go to the Museum of ABAP. So I say thank you for the nurses, the work they're doing. I can continue. That's a good way of doing it when we meet and can share each other's worries about how nurses are doing around the world. I think it's very important. Here in Sweden, we have a lot of work to do. As you know, we haven't done as the rest of the Europe. We didn't shut down the whole country, and we didn't shut down the primary healthcare and everything like that. So nurses and the pandemic and the COVID-19 has really shown how nurses are working and the lack of nursing even in Sweden. And we compare to the Nordic countries, we can see that we have a lack, mainly in the home care and in the healthcare at the municipalities. Nurses are the largest healthcare professionals in the field of healthcare, even here in Sweden. The report briefly summarizes current and scientifically based knowledge of global health and view the needs of the nurses from the public health care perspective. I think it's very important. And I think the home care nurses and the municipality home health care is very important to look at. This means for us here in Sweden that the state, the region, the municipalities, the private care providers and the social care providers most otherwise contribute to solving the provision of skills in healthcare right now. And in this situation that we are in COVID-19. Next slide, please. All parties here in Sweden accept that the skills shortage for nurses requires a relative pay change, really, because the young people, they don't stay at nursing work as long as we need them. Work in healthcare must entail a reasonable salary, and that's also important. The unhealthy and high staff turnover that we can see right now, that can be attributed to the lack of work environment and poor staffing of nurses must be stopped. And I think we have the support of all the people right now and all the parties right now in Sweden. Therefore, all employers in good cooperation and dialogue needs to carry out strategic work to prioritize the working environment, and we are doing that right now. At the same time, it's important to understand that the provision of skills also relates to how the operations can develop the skills of the staff who already are employed, and we can see that we have poor time to do that when you are employed. And as an organization that Vårdförbundet are, we have examples that we have proposed to the state and to the regions, and we have in some of the regions, and it's working good, is the example of introduction of a nationally regulated of academy specialist training for nurses. And we have done that. That still is not getting us the amount of nurses that we really need as specialist nurse. So we are talking about how do we have to work on that. The next slide. Yeah. And point number 5 is that the staff time spent on administration must be reduced, and we see that a lot right now. But the big problem is the upgrading of healthcare informant systems that are ongoing around Sweden needs to result in systems that support and do not interfere with staff in caring. And we see that we have a lack of systems who really help us. The little paradoxically about that is that at the same time we need the information system must contain more information. So we need big data, we need more data, and we need systems that really help us. For example, the National Board of Health and Welfare should recommend the nursing documentation to be introduced by the CMP, and we have worked together on that really big to get it on. That's my points, and I leave the word to Amy.
Next slide, please. So what I would like to highlight is that the strength of this report is that it's linked to the Agenda 2030 and that it describes and refers to evidence for the importance of nurses within a wide range of nurses' different areas. And all students in Sweden who undergo nursing education at basic and advanced level receive a university diploma in nursing and a degree of Bachelor Master of Medical Science with a major in nursing. or a majority in nursing. However, there are political forces that are constantly trying to change this, but I can assure you that we resist. And this report also highlights the need to include the 6 core competences, as you all know, is person-centered care, teamwork and collaboration, evidence-based practice, quality improvement, safety and informatics in education. And in Sweden, we have worked since 2010 to include these competences in nursing education, and we have succeeded. We also have the core competences in the Swedish description of competences for nurses. And the report concludes that there must be an investigation in nurses' education, working conditions, and conditions for leadership that is crucial to achieving the health for everyone. This is also relevant for Sweden and therefore very useful for us. But I am afraid that I have to tell you that Sweden belongs to a minority of countries that don't have a leadership program for nurses, and healthcare to a large extent lacks nurses who participate in decisions for both healthcare and the conditions of nursing. And these are some things that we are trying to change, and we will continue to do. We think that nurses must have a seat at the table, and that is on all different levels, and that nurses must have not only have responsibility, we also need to have the mandate to make changes. So next slide, please. So what are we doing in JSNO? Well, we will try to spread and arouse interest in the report among our members. Among other things, members' newspapers and social media. We will write debate articles. And as a professor at Malmö University, I also think that this is very important that we include our students so they are aware of the report. So we can influence decision makers as well as politicians and healthcare providers to implement the WHO recommendations. We think that would be very important for us. And we have spoken today about COVID-19, and I can tell you that in Sweden now, when the importance of nurses are on every single newspaper every day, we actually have increased the application to nursing school by 34%. So young people, I think it's most young people at least, they have seen the importance of nurses, and many young people want to be a nurse and be in the front line. So that is something good about coming out from the COVID-19.
And I just want to add that we also see the membership increasing in the member organization in our, and it's getting really big membership. So I think just showing what we are doing for the nurses out there is really getting us on the front door in every home right now. Thank you.
Absolutely, and I think that the report can help us with this coming out to everyone. So thank you so much.
Shineva, Ami, thank you so much. It was excellent. I think that you set an example for many countries in the way in which you've clearly cross-referenced and aligned your country priorities, your association and nursing priorities with the report, and started to describe how you're thinking that you can use the report to advance areas which are priorities for you in Sweden. And we'll come back to that at the very end, because I think, you know, how we use this report from this point onwards is something that we need to talk about. We need to think about. But you've shone a light on how that can be done.
Yeah, I just want to add that it's very good that every country can just pick their own result as well.
Yeah.
That is very good.
Absolutely, that you're tailoring it to your individual circumstances and context. I thought it's an excellent example of how to do that. You're right. We're also watching you very closely in relation to COVID. I think the increase, first time that I think from the reaction from other participants, first time people had heard that increase in the number of applicants to be nurses, which is incredible, because some of the discussions that we've been having about this could go either way. It could see an increase or equally, might it see a decrease, people seeing that the profession isn't being supported. We've had separate webinars on COVID already. We've had 3 already. We've got one for Latin America next week. We're going to come back and do more on that. So there will be the opportunity for that. And also just to say that we are really thinking very, very hard about how we message all of this around the 12th of May. There's a lot of resources that we've already brought forward, but this moment of opportunity that we have is something that we're going to try and focus down a little bit more on the 12th of May, pulling together State of the World's Nursing. So be assured that the President, the board and the ICN staff have been doing some very active work on that. So there'll be more of that to come forward. I'm going to go to Jim in just a second, but before I do that, Matthew, there's a couple of questions which people have flagged about the data that's in country reports, and if associations don't recognise or have questions or issues with data that's in country report. Could you just say a little something about if an association looks at the country report data, has questions or issues with it, what they should do, who they should contact, who they should speak to?
Yeah, of course, it's perfectly understandable that you will find sometime something that might be a discrepancy with what you know for your country, maybe because of the definition or because the way the data were reported. If there is any question, you should send us these through a mail, that is hrhstatistics@who.int. I will put that in the chat box, and we'll make the linkage between you and the National Workforce Account focal points, because through that process of data monitoring and report, we discovered some difficulties, and it was a good thing to have this engagement by different stakeholders. Maybe it was not the case in your particular country for plenty of reasons at national level, but it's always good that you get involved in this discussion at national level to improve the data, improve the reporting, improve the quality.
Matthew, thank you for that. You're right. There were some countries whose associations really got stuck into and involved in discussions at a country level. There were others where that was, frankly, it felt as though that was made more difficult by the countries. But as you say, there's a really big open door there for us that we need to push through. So thank you for the practical advice on how to do that as well. So Jim, you've nobody would believe this looking at you, but you've been around nursing workforce for a few years now and have seen it from a range of perspectives. Worked with WHO, you've worked with associations, you've worked with educators, you've worked with ICN. I'm not sure who you haven't worked with over your career. So I think you do bring quite a unique perspective to the report, to the current state that we find ourselves, the circumstances that we're in. What would be your reflections in terms of both the report, but the context in which it lands right now? Jim, to you.
Thanks very much, Howard. I'll just start by saying good dog to my colleagues in Sweden, and bonjour, bon dia, buenos dias, and to my friends in Australia, good day. I'm going to make, I think, 3 points. One is to relate to the issue that we've already discussed around the data at country level. The second will be more about how the report is being presented. And the third is, I think, the most important thing, which is where do we go from now on? So there's the kind of 3 points I'll make. But before doing that, I do want to recognize the heroic efforts of Kari, Matu, and all the others who've been involved in developing and preparing the report. I think what we've got to recognize is that between a full draft of the report and the report being published, the world changed. COVID impacted. So to get the report out was a huge effort. The bigger effort is going to make sure that it continues to retain relevance as we move forward, recognizing that the world has changed and there will be a new normal where we will not go back to the way the world looked before COVID. Having said that, inevitably, I think my comments will come across as identifying areas where there's room for improvement. And I think that's my purpose today. So as I said, 3 issues I just want to highlight. The first is the country level data and the importance in getting that right, because it's the building block on which all the rest of the information, the analysis, the interpretation arises. And I'm aware in looking at some of the country reports that I would disagree with some of the data items, and I'm aware that during the teleconference today, I think Canada and Denmark have both flagged that they are questioning some of the data elements. The critical thing here is to recognize, as already has been said, that this is a live project. It's not a one-off. So there is room for, and there must be scope for improving, enhancing, and getting that data better. And NNAs can play a critical role there in looking at the country level reports and where they think there are issues that require questioning or improvement, that they get involved, they email the right email, and they also get engaged at national level. I think there are 2 or 3 definitional issues that probably explain some of the differences in opinion about data country reports. One has already been highlighted, and that is the extent to which nursing data at national level fits easily into the ISCO definitions, particularly that of associate nurse. And I think that's something that needs revisiting and refinement, because I don't think we're always getting it right at national level in terms of the reporting at the moment. The second are the issues around, are we reporting on nurses who are registered, who are practicing or employed or only employed in the public sector, and ensuring that we get comparable data across countries continues to be something we need to work at. The third point is the critical issue of mobility and migration. The report conflates foreign-born and foreign-trained definitions, and I think we need to be aware that those 2 data definitions will present a different picture in terms of what we're looking at, and we need to be confident that we are presenting and explaining using the right definition. So that's point number 1, which is the let's make sure we continuously improve the country level data. The second point is more about the report itself and presentation and interpretation of information. Howard, you've already said yourself, and I'd reinforce the point, we need to be confident that in some cases the actual response rate is relatively low compared to the total population of countries, so that we're not overstating a finding which is actually coming from only a few countries. That's something to be aware of when we look at individual graphs and figures. The bigger issue, though, I think, is to recognize that this is a heroic effort. It's the first time we've had this data in a comparable way. And data is only neutral until someone starts using it and interpreting it and presenting it. And I've worked in many countries, and you will find that ministers of health and governments are very happy when their country looks good when compared to other countries, irrespective of what the data is. They're less happy when they're not so good in comparison to others. So when we get to the point of working with individual countries, we need to recognize that there are entry points there, but possibly resistance to accurate data if it doesn't present a good picture. So there is a need to have strength when interpreting the data and presenting it to governments at national level. And this, in part, comes back to the critical issue of nursing leadership and the role of NNAs in engaging at national level, both to ensure the data is accurate, but then to ensure that how the data is interpreted, presented, and being used to justify action or inaction is appropriate. And I think there will be cases where there needs to be significant pushback from NNAs to ensure that governments are doing what they need to do in these circumstances. The third point I said I'd make is the looking forward one, and that in particular picks up on the policy options that have been so ably set out. And I think the first point to note there is that there's virtually no country in the world that couldn't be doing something on each of these policy options. There is room for improvement across all of them. The question then is, how do you prioritize? Where do you need to focus your efforts? What's most important? Where is there need to be sequencing particular policies? And that's where the suggestions around policy dialogues and national engagement are going to be so important. I mean, if I'm allowed my own two ABBA songs of the moment, the name of the game is going to be money, money, money. It always is. When it comes down to it, and we're coming out of COVID, many countries will be facing very challenging economic times. There will be big pressures on funding availability, competing pressures on that funding availability. And the need then will be to use the key messages in this report, updated when appropriate, to ensure that nursing has a very strong evidence-based voice when funding is being allocated and policies are being determined. And that's not a new message. That message existed pre-COVID, but I think it will be even more pronounced in the world that we're moving into, the new normal, where certainly initially there are going to be tremendous calls on funding availability, and nursing will have to be very strong to ensure that its message is heard. So that's just a few introductory remarks, and I look forward to further debate in the time we have left. Thank you.
Jim, that was as always was excellent. Thanks so much for that. And I also just want to say on behalf of ICN, the last couple of years, the support that you provided to ICN, some people on this call are aware of that, but others might not be. You've been hugely helpful to us in terms of our ability to engage and ICN's expertise on workforce. So thank you personally, and I look forward to that continuing. I think that you raised migration. I'm really glad that you did, and I know some other people have reacted to say that the point you made about foreign trained and foreign educated and how we need to be careful with that is a really important one. As Jim and I both we were talking about this just the other week. What's interesting about the report is that migration is the single issue from the report that has generated the most media interest that Jim and I have been aware of. That media have been interested in the overall report, but the one discrete area of the report that we've had a regular flow of media inquiries is around migration issues. So important to highlight that. And also the use of the ISCO codes. This is something that, and I'm sorry that both Carrie and Matthew knew that I think at every meeting I banged on about the limitations of the ISCO codes, because I know from our associations what a sensitive and challenging issue it is. The report, those of you who've seen it, but those just to reinforce, whilst we have the 28 million figure, then it is broken down into 19.3 million who are the professional ISCO code, which I think we can be pretty confident are registered nurses because it cross-triangulates to the at least 3 years nursing education. There's a 6 million figure for associate nurses. I think that there could well be some non-registered nurses who may have slipped into that 6 million figure, but in terms of a global registered nurse number, those two together around the 25 million mark. The report says there are 2.6 million who weren't classified into either. This is a personal view, and Carrie and Matthew have heard me say it before. I think that there's a good probability that if they weren't classified into either, then they may actually be support workers or assistants as well. So we can continue to have that discussion, but I'm grateful that Carrie and Matthew, the report does set out those 3 different categories and does the best that you could with the data to aggregate. Jim, I'm going to just throw one question back to you, and everything that you said about the importance of the data, improving the data, but we have this report now. If I was to say to you, when should we be doing this again, at the risk of seeing Carrie and Matthew's hair turn grey as I ask that question, yours, sir, I'm afraid already have. But give us a view on sensibly, realistically, when most helpfully, if you have a report like this for the first time, we should be pushing to do this again.
I think there's a 2-level response to that. One is the country level data. I think that's more or less a process of continuing improvement. So if there are issues identified in the country reports, those need to be resolved as soon as they can. So that's an ongoing basis. But in terms of the much larger effort that needs to go into interpretation, analysis, and publication of full reports, I'd have thought that anything less frequent than about once every 3 years, and you'll lose the ability to trend and track. But much more than that, and it becomes a very significant resource effort. So I'd have thought once every 3 years for a main report, but continuous improvement on the data, says the man who hasn't got anything to do with budgets.
Jim, thanks. It's also very helpful to have that view when we come to the where do we go from here and the future thinking piece as well. I can see I can see from the Q&A, and Carrie, Matthew, I'm going to come to you with this one initially. Our good friend Jose Luis from the Consejo in Spain has asked about how you came to the prediction, the forecast of the numbers needed, the demand numbers that were needed, would be needed by 2030. So if you're, I know that this is hellishly complicated, but if you're able just to give an insight in terms of how you do that forward forecasting, and also I know that from discussions with colleagues across Europe, there is a concern, a risk that not the associations, but some European countries might have a cursory look at the report and think, we're doing okay, actually. Europe isn't so bad. The big problems are in Africa and Southeast Asia. Clearly, from an ICN perspective, we don't think there's any room for complacency in Europe, but it would be good to get Carrie and Matthew's view on that question as well, the situation particularly for Europe. Actually, I think it probably applies to North America as well. Carrie, Matthew.
I can already jump on the question around the forecast, how it's done. It's a very, very basic stock and flow model. We start with the stock as of 2018, and we make this stock being aging through time. So we remove from that stock those who retire on an annual basis. And from that stock, we add those who are entering the market, those graduates. That's basically the way it's done. There are multiple ways where you can project the stock, for example, doing some linear trend or some other model. But this type of model usually use only the density available and do not take into account this aging situation and this graduation situation. And that's the reason we use that one, because we wanted to use the maximum information we had, which was adding this age and this graduation. These are projections, so they just reflect the situation that we see right now with all the difficulties and the caveat that we mentioned. As for any projection, these should be interpreted with caution because that could change rapidly through time.
Thanks, Matthew. Carrie, Europe, in terms of looking at some of the regions, Europe and the Americas, where the shortage numbers don't look as significant as they might do for other areas. Can they be complacent and think things are okay for them?
Thanks, Howard. No, I think Mathieu could probably give some more detail on how the shortage was calculated using the benchmark, which some countries, as you mentioned, in Europe and in the Americas were above a certain benchmark for which the shortage was calculated. But what's really clear in the report, and one of our main messages, is that there is no place for complacency, given the aging of the workforce, given the level of recruitment from certain countries and the level of domestic production. There's definitely room to increase production and to look at retention policies in countries that are going to bring in and keep in young nurses into the workforce. So that's something that we complacency is not one of the policy options, no.
Carrie, thank you. Thanks for that. Geneva, Amy, Jim, yes, followed the trend and said it's name of the game is money, money, money. From a Swedish perspective, how concerned are you about the money? How do you think that might play out? How are you thinking about that from a JSNO perspective?
Do you mean the salary, of course?
But both salary, but also investment, economic impact of COVID and investment in health going forward.
Yeah, I think the salary is very important for those 33% of the young people who have applied for being a nurse at the universities. I think that's one of the big questions. I think that if the government wants them to stay, we have a shortage after 2 years. After 2 years of working, almost 30% are quitting, getting off the job. And the environment and the payment is one of the questions that they say are the problems. But I think also that the government really have worked with the economical situation in Sweden is quite good, I can say. And the government have sent a lot of money for healthcare to the municipalities and the regions right now. And they are taking an oversized view of the healthcare overall, because we have the regions who are the main governments of healthcare in Sweden. But right now, the government, the politicians are taking an overview and taking responsibilities for many things that didn't work at the region side. So I think we are going to manage that. And they are saying a lot of the people who are unemployed after this COVID-19 pandemic is going to be needed in the healthcare system and in the social care system. So bring them on, I say. If they are good enough, we will really need them in the future. Amy, are you?
Yeah, what I'm thinking of is that I think that our politicians actually now are aware of the work that nurses actually are doing. And one of the biggest problems we have had for the last 10 years in Sweden is that they're always talking about we need more nurses, we need more nurses, not we need to have our nursing staying, working as nurses, because we have a lot of nurses in Sweden, but they don't want to work because of the environment they are working in, and of course also the salaries. And I think that everyone is now well aware about this, and that has been a problem that I think they have opened their eyes for.
Yeah.
That's thanks both. That's it's incredibly helpful. One of the things that Jim helped us with at ICN just last year was a briefing that looked at retention, available on the website, and it's been a really strong message from us as well that that we focus as much on retention as we do on recruitment. We've got some more work that Jim's helping us with to look at aging as well. But it's a nice segue as well to think about the future and where we go from here, Carrie. And I'm going to come back to you in a moment to give us some of your thoughts about what the next steps are, what the next stages are, how the report might fit with the production of the next global nursing and midwifery strategy. I know that we have got Peter and colleagues from JPIGO, Peter Johnson, on the call as well, who've been doing some really helpful work thinking about next stages. And also just to shout out, JPIGO and Women in Global Health hosted a great webinar last week thinking about the gender issues raised in State of the World's Nursing Report. We haven't had a chance to talk a lot about that today, but I know that Peter will be very happy to share the recording from that report, from that webinar, which specifically focused in on some of the gender issues as well. But Carrie, yeah, where we you're thinking, WHO's thinking about where we go to next.
Right, thanks, Howard. And I want to thank Jim as well for his reflections. Those are really useful and thoughtful. And I think in terms of where we go next, it is relating closely to each of those three areas that he mentioned. So one area is continuing the data quality level in country. NHWA is a continual process that has a strong intersectoral cross-stakeholder engagement at country level, as Mathieu described, and it's really important for the National Nursing Associations to be engaged in that process. Part of the process is also that then the data that is reported is published and it's online. It's available for everyone to use for research, for advocacy, for policy dialogue. So that in terms of keeping the data, improvements in the data and the reporting, that's definitely somewhere that we continue to work towards. And that the fact that the report is based on the NHWA system makes it much easier to do reports like this. So it's not a novel data collection data reporting every time. The countries are routinely reporting this data that we pull and clean, validate with them, and then can analyze and publish. The other area is the policy dialogue, and that is something that we always considered as the next phase of the SOAN report. It's not putting a report out and having it sit on the shelf. It's really about leveraging that data, using the evidence for those arguments for policy reform, policy development, and investments. So as Jim said, it's there's going to be a lot of competing attention, but hopefully then the message around investment and being able to use the report to highlight those areas for priority investment is going to be useful. So WHO, we're working through our regional offices to work with all of our countries to hopefully hold policy dialogue. Obviously, we'll be in the context of the country in COVID-19, so it might be different than we initially anticipated putting together that theory of change. But policy dialogue and evidence-based decision making is definitely what we want to support our member states in doing and using the report. So I will say that's a tie into something you also mentioned, Howard, which is the strategic directions for nursing and midwifery. That's something that is currently from 2016 to 2020, so it needs to be updated. And obviously the data and the evidence from the State of the World's Nursing Report is an important source for developing the next iteration. So as Jim mentioned, looking at how can countries implement the policy recommendations? How would they prioritize them? How would they sequence them? That has to come into a strategy that will work together with stakeholders and all across all the regions to develop. We plan on doing that with ICN and ICM as a starting point at the Triad meeting, which was initially going to be held in May, but we're looking to how to hold that virtually, and at a time that we can have that available with all the functionalities virtually. In the Triad meeting, as you know, we're trying to work on covering the policy dialogue, sharing the how-to and the tools for policy dialogue, as well as getting some of that feedback from all participants on what are the priorities from all these policy options and how would you implement them? What are the supports and how do we articulate a global strategy for nursing and midwifery that uses all the evidence and gets us on a path that all countries can buy into for a decade of action that will take us to nurses and midwives driving the successful achievement of the SDGs.
Carrie, thank you so much for that. Jim, Shaneva, Ami, and Annette, we're drawing to a close. So I'm going to come to each of you in that order just for a couple of last thoughts in a moment, and perhaps some last thoughts from all of you as well about where we go from here. Carrie, I think it was incredibly helpful just to hear your thinking in terms of how SOAN is integrated into other areas of WHO work over the not only just over the next month, but over the next 18 months at least, or even a decade. And of course, that's something which and Annette may say more about this as well. But in the regular catch-ups that Annette has with the top of the tree at WHO as well, there is very clear support there for that as well. So Annette, you might want to say a little bit more. Thanks also, Carrie, for mentioning the triads. Carrie and I have been in regular contact about those, and we are committed to have some form of triad meetings happen. Of course, it will have to be virtually, but to happen as soon as we can. I know people are constantly sending emails to ask the exact details. We are trying to pin that down as quickly as possible, but we are actively working on a virtual option to happen in the next few weeks. And SOAN and COVID, of course, will be the major focuses of those discussions. So, Jim, first you. Final thoughts for us.
I think the positive is that for the first time we have a report which provides a real global backdrop on what the nursing workforce looks like and what nursing labour market dynamics look like. The caveat is that any time that it is being applied and used at country level, we need to be very clear that this is a backdrop. It's not a detailed picture of any one country. And I think that comes through very strongly in the discussion around definitions of shortages, for example. This report provides a definition of shortage, which is about, does the country have sufficient nurses numerically to meet a basic package to cover UHC? Many countries will aspire to have nurses beyond that numbers to provide higher levels of care. That's one dimension. The other is we need to be very clear. It's not just about numbers, it's about skills. And that's the sort of issue we need to be looking at country level. How many advanced practice nurses do we have? How many do we need? So it's a really good point of progress that we've made, but we need to ensure when we come to country level dialogues that this provides a backdrop which we can improve, but it needs enhanced and it needs country-led dialogue when it comes to what to do at country level.
Jim, thank you for that. Shaneva, Ami, your final thoughts on where we go from here.
I can start and then I give the floor to Ami. I agree with Jim, but Jim, I think it's also important that at the next meeting at the ICN, when we can have that, I think sharing the good examples, how we are working in the different countries with the policy making, with the politics, with the regards of nursing education and things like that, to learn from each other. That's one of the points that I think ICN can take, that share and make us sharing the good examples. But in the other question, I think as James, it's great to have the first report. It's different. We can't manage the figures with all the countries. We can do it by the Nordic countries and compares with the Nordic countries. We have almost the same healthcare. So for us, it's helpful, really. Thank you for that. Ami.
It's good to unmute. Sorry. I think it's very good report, and I think that Sineva and I can use it within JSNO, but Sineva has it as the president of the trade union, and I as am the president of the professional organization, the Swedish Society of Nursing, and we can work both together, and we can go into the politicians from two different angles to discuss about the report, because I think the reports really help us. So I'm very happy, and we have it on we have a board meeting next week in our association, and we have the report on the agenda, so we will absolutely work with them. So thank you so much.
Geneva, thank you both. One of the things that we've been trying to do at ICN in relation to COVID is to absolutely to learn and to share the events and the webinars that we've been holding. Look, I think that, and the president may say more about this as well, we have really seen how associations' roles have come to the fore in many countries, have played a really proactive, important role in leading responses to COVID, and the model that you, the example that you set in terms of how different organisations, nursing organisations, collaborate and work together is really important for colleagues. So thank you both, and both your organisations separately and through your partnership for everything that you're doing. Madam President, the final words, as always, are to you.
Thank you, Howard, and thank you, everybody, and thank you to the panel. It was a very rich discussion, and it always strikes me when we have these webinars how much we learn from each other, and how much stronger we are if we work together. And as we have heard, three of the issues that I picked up from the discussions today was that, you know, everyone has had to look at the individual countries, and it is only a starting point. It is a live document, and we can feed into better information in relation to our country reports to our governments, and we can challenge them, and we can insist that the information that they have provided is not or is correct. And even Howard mentioned the high-level advisory group that was set up by Dr. Tedros to look and see how we'd all work together for the Year of the Nurse and the Midwife. And it's made up of the International Council of Nurses, the International Council of Midwives, and Nursing Now. And it has its meeting generally we try to have it every month online. And these are some of the issues, like we talk about the Year of the Nurse and the Midwife, but we also talk about COVID-19, and we also talk about this report. And there has been so many times we have said to Dr. Tedros at that meeting that the governments, as Jim rightly said, like to portray the very best, you know, presentation of how their country is doing. It may not be the accurate assessment, and that's why we need the National Nurses Association to feed in the correct information. It is so important that, you know, the people on the ground that know the situation feed into the governments, because we know that they are going to give the very, very best, which is not always the accurate report on how many nurses are in country and how their education system is doing. The second thing that I was very impressed with was when Sweden, and I think Jim fed into this as well, is that there's policy options for all of us, and that they're relevant to all countries. what we have to do is to link them to our agenda and to our own priorities. And that's, you know, a very important point. And I was struck by the fact that one of the things they said was to have it in the curriculum. I think that's something that we don't do and we should do. There also was a lot of comments about the chief nurses and having leadership positions. And I think you yourself had said that, Howard. And it's one of the things that has struck us very forcibly. You can have chief nurses, but if you don't have chief nurses at the same level as the chief medical officer or at the strategic decision-making table, it's not of any great value, because they have to be there to make decisions about a health service and about the nursing profession and where we are in the midst of that and what we can do, because we are central to the whole health service. We are the backbone of the health service. And as has been rightly said, and these are all the things that I'm taking, particularly because the advisory group have been suggesting that we need to have a strategy going forward from this State of the World's Nursing and Midwifery report. And all of these issues will be fed into that. But one of the strongest things, and I think, Jim, you made it very forcibly, was funding. Funding is going to be a real issue. Okay, we have seen, and it's been very widely portrayed, how great nurses are and how much they have done in COVID-19, and the media have played a great role in that, and so have the National Nurses Associations. But come the economic crisis, then of course everybody will be fighting for a piece of pie, and it worries me because even I hear it now, they're saying how much money they have invested in COVID-19. You know, that they have invested much more money than they have had intended putting into health. So it will be a fight on our part to make sure that we have the evidence there, that we have the documentation, and that we fight for a very good piece of that budget when things get a little bit worse. And they will get a little bit worse. But we are strong, and we have a good case, and we have a good case from the State of the World's Nursing. It's, as Jim said, it's a live one, but we can work on it. So that's something that we will be taking to the high-level meeting of the advisory group. I think the next meeting is probably on Friday. So I think all it leaves me to say is just one or two things. I know retention. Retention has always been high on, I think, every NNA's priority list, including ICN. We have been saying that for so long, that nurses, the best nurses will get out, they will be entrepreneurial, they will do their own initiatives, and they will not be left at the front line because we are not looking after them and we're not supporting them. And yet they are needed in primary healthcare, they're needed in relation to taking on caseloads if they're advanced practitioners, or they're needed health promotion, and they're certainly needed right now in COVID-19. I won't say any more than that, but just to thank everybody, thank Chipago, thank the World Health Organization, because it was a heroic effort to get this done by April. It was absolutely. And to thank the workforce team, Carrie and Matthew, and all the rest of the team that were involved, the chief nurse, Elizabeth, and Jim for all his advice in relation to, for any time that we ask him. Jim Buchan is there, you know, every day for us, and has been for years. Has Howard said, I won't say how long, but he just seems to be always around to support us. I think we'll make him an honorary nurse, but anyway. So thank you, everybody. And I think, Howard, are you going to sing us out with a NABA song?
No, Madam President. Listen, we danced in Singapore. I don't think people are waiting for us to sing now. Thank you, Annette. I just wanted to say, obviously, our next big date in the diary, the 12th of May with International Nurses Day. As I said, you've already had the resources for us for International Nurses Day, but we are really thinking about how we also use the 12th to highlight the moment of opportunity that we have. So you'll see more from us for those plans. I wanted to again thank JSNO for co-hosting this webinar with us. And I think I'm right in saying that we are also talking to you, with you, about having the Workforce Forum next year. So there will be an opportunity for the museum and for
early
to say it, karaoke as well. But the last thing, listen, I have to all of the panelists, you have been our super troopers for this webinar. So to all of you, the panelists, thank you for your time, your expertise as well. Stay well, stay safe, everybody, and we'll be in contact again soon. Bye-bye.
Bye.
Welcome to Sweden.
Thank you. Yeah.
Bye.
Bye-bye.
Oops.